Hello, it's a great pleasure for me to be able to present a topic that is near and dear to my heart. I apologize for not being able to be in person. So a pinch of snuff could be used to produce a sneeze on demand. And of course, this meant that if you were bored with the conversation or to show your status and be pretentious and disrespectful, you would get out your snuff and sneeze. So I hope that you will not do that today. But of course, what I am about to talk about hopefully will not be nothing to sneeze about with the small blue round cell tumor category. I always like to start off with a case, and in this example, it's a 29-year-old who presented with progressive sinus pain and diplopia. Left proptosis and exophthalmos were noted, with CT demonstrating a 1.8 centimeter lesion. So here you can see the 1.8 centimeter lesion, a different view showing that there is actually displacement of the globe, as can be seen radiographically. I always try to put patients in context, and so I couldn't resist selecting a patient here, but this is, of course, not the patient. Let's go and drive this particular case, just so you'll be able to look at it with me, and so I'll drive it here for a few moments. As you can see, it's always nice to note first the bone, and there's several fragments of bone over here, and as I look at these fragments of bone, you can see that they are this neoplastic proliferation that is actually going into the bone and is associated with an osteoblastic reaction to it. So it's my view that there is actually genuine destruction of the bone by the neoplasm rather than just remodeling. As you look at these areas, I think you can see that there is a small blue round cell type proliferation. So let's go out and kind of look at the entire specimen again, and let's start off at the upper corner, just to show that there are areas of tumor necrosis present over here. If I go to slightly higher power over here, there is squamous epithelium. Of course, when you're in the sinonasal tract, the question here is always, well, is that the surface, or is that actually part of the neoplastic proliferation itself? And when you go to higher power, I think you will notice that there is a genuine monotony to what you see in this particular area. It is actually quite similar no matter where you go, that all of the neoplastic cells tend to have a very similar and monotonous appearance one to another, with a relatively high nuclear to cytoplasmic ratio. Again, areas of necrosis are easily identified, but then you come to areas like this, and I think that that particular space over here is genuine. In other words, I think that this area of abrupt squamous differentiation with a keratin pearl formation is part of the genuine neoplasm being seen in this case. So what would be your diagnosis? Well, I'm not going to make it simple, and I'm going to give you a number of different choices, all of which are based on a molecular technique or a molecular profile. And that is just to serve as an introduction to what I'm going to be able to talk about here. And that is, of course, the small blue round cell tumor category, as it is specifically related to the sinonasal tract. Now, as you can see, I have kind of aggregated some of these based on the first letter of their name, and you will see that there are a lot of them. I'm only going to highlight the ones in green that I'm going to discuss today, but just be aware that several of these other lesions can potentially occur in this location, and of course should at least be considered as well. So why did I put it in this order? Well, it's always nice to try and have a mnemonic to remember things. And so for me, at least, the Mr. Sleep is an excellent way to remember the small blue round cell tumor category. I know that there are gynecologic lectures occurring later on in the presentation, so maybe Mrs. Leap, if you prefer that as your acronym. Whenever I think about the group of small blue round cell tumors, they are really heterogeneous, even though they have a relative monotonous histology. And so there's significant overlap clinically, a wide age range at initial presentation, the histology showing quite a bit of similarity from case to case. And then, of course, the biopsies in the sinonasal tract are frequently quite small, or they have frozen artifacts, or they're crushed, or there's something else that comes into play. So it is a very challenging area in which to be able to get a diagnosis. However, I do feel that applying a pertinent immunohistochemical profile panel, and here you will notice that I have selected 8 different antibodies to perform in this case, with the INI1 kind of given in gray here, since it has a very specific location and tumor identification. But overall, this particular panel will give you a remarkable amount of overlap as well. So if I highlight this for all of the neoplasms, you can see that just because you've done a panel does not mean to say that automatically likely the diagnosis is going to appear to you, and that you actually do need to do some additional work in order to be able to come up with an accurate diagnosis in this case. So let's start off with the differential for this. And of course, you have to start with squamous cell carcinoma no matter what, because of course the non-keratinizing squamous cell carcinoma is the most common neoplasm in this anatomic site, with the non-keratinizing giving you this kind of ribbon-like growth pattern with an absence or limited maturation process. Quite frequently in the maxillary sinus, although the nasal cavity can be affected as well. And it's kind of the smooth interface with the adjacent parenchyma that you see without any areas of keratinization, usually a high NC ratio, some peripheral palisading, often a very high mitotic index with tumor necrosis. And so it is kind of the blue round cell classic. As you can see from the immunophenotype, pan-cytokeratins, and then any one of the other markers for squamous differentiation like CK56, P40 or P63 are going to be helpful. And you can see that I've put in P16 because many times these tumors may be positive, even though in fact it is not related specifically to a biologically active HPV. So on low power, you can see this very nested ribbon-like architectural appearance to the neoplastic proliferation. Another example here demonstrating a slight area of peripheral palisading that gives you a hint to the underlying diagnosis. So here is a very strong and diffuse P40 in this example. And of course, that should help to confirm the diagnosis as long as the other markers are going to be in place as well. So sinonasal undifferentiated carcinoma, as you can imagine, is a tumor in this location that lacks any glandular or squamous features and isn't otherwise classifiable. So in fact, it is a diagnosis of exclusion. And so let's talk about all of the other things that you need to exclude before you reach a diagnosis of sinonasal undifferentiated carcinoma. And that is starting off first with the SWE/SNF complex deficient carcinoma category. This is one where there is a poorly differentiated epithelial neoplasm that is specifically related to one of the members of the SWE/SNF complex without showing any other histologic evidence of a specific tumor type. So the SMARCB1 is, of course, the most frequently identified, but SMARCA4 deficient carcinomas are certainly recognized in this location as well. Well, you may say, why are you saying SWE/SNF? Well, let me just tell you that SWE/SNF related matrix-associated actin-dependent regulator of chromatin subfamily B member 1, which is what SMARCB1 actually stands for, is just an incredible mouthful, and so we don't like to actually repeat that every time. Suffice it to say that this is the sole genetic driver for these neoplasms, and therefore the detection of them kind of truncates any of the other evaluation that you may need to do. I will say that because it is a biallelic inactivation of SMARCB1 as the most frequent finding, just recognize that it is in a very close proximity to the EWSR1 genetically, and therefore a FISH may give you a false positive in some of these cases. The tumor tends to be divided out into, these three major groups: the SMARCB1 deficient carcinoma, SMARCB1 deficient adenocarcinoma, and then the SMARCA4 deficient carcinoma group. So either of these SMARC molecules can be detected as a loss in the neoplastic cells. So for the SMARCB1 deficient carcinoma, which is what I'm presenting here because of its relatively monotonous basaloid or plasmacytoid, even rhabdoid feature, with a very high NC ratio, prominent nucleoli, usually high mitotic index, and of course no evidence of either squamous differentiation or glandular differentiation, and most commonly does not have any evidence of any surface dysplasia, which is a helpful hint to the underlying category of diagnosis. Of course, you can have sometimes a pagetoid spread into that area. Now, the SMARCB1 deficient adenocarcinoma has similar features, except it's arranged in a glandular distribution, many times showing yolk sac type features as well. And then the SMARCA4 deficient carcinoma group tends to be a much higher nuclear grade, undifferentiated large epithelioid type cells with vesicular chromatin, and not as frequent an identification of the rhabdoid or basaloid type cells. So here you will notice ribbon-like pattern, so you can tell immediately this is quite similar to the sinonasal undifferentiated carcinoma on low power, and this is why the tumor has been previously classified under that particular rubric. When you go on to higher power, you can see that there is a remarkable pleomorphism present within this particular area with tumor necrosis easily identified. Here are a few areas that show a certainly plasmacytoid to rhabdoid feature in many of the neoplastic cells. Another area here showing very prominent nucleoli within widely open and vesicular nuclear chromatin, with even some areas of cytoplasmic globules identified. When you go up to higher power, however, I think you can now see the areas of this kind of rhabdoid or plasmacytoid architecture to the neoplastic cells. And whenever I see that, that is one of the tip-offs to me that potentially I'm going to be dealing with one of the SWE/SNF complex deficient carcinoma groups. And in this case, the only one immunohistochemical study that is required is, of course, showing INI1 loss, which is the representation of SMART-B1. You can do BRG1, which is the representation for SMART-A4, but in this particular instance, it's the small blue round cell category that we're presenting here this afternoon. So again, if you look at the immunohistochemical profile, you can tell that there are quite a few of the epithelial markers that are present, but of course the INI1 loss is what helps to confirm the neoplasm in this example. So nut carcinoma, as you know, this is a fully differentiated carcinoma group that has evidence of abrupt squamous differentiation and is of course defined by the presence of the nut gene rearrangement. And of course, that is the nut M1 specifically. You will notice a very young age at initial presentation. And so whenever I have a case that seems to be a squamous cell or areas of abrupt squamous differentiation in a patient less than 30 years of age, I certainly do think about the nut carcinoma category much more strongly. The etiology is not related to anything else, so it is not associated with the human papillomavirus or EBV or any other sort of viral infection or smoking, so it is specifically related to this genetic abnormality. As you can see within the head and neck, the sinonasal tract is one of the most common presentations for this, and be aware that it is not always midline, and this is the reason for removing midline out of the name in the most recent classification to now just call it nut carcinoma. It's arranged in sheets and nests, and I think one of the things that is the most helpful is, again, this very monotonously similar neoplastic proliferation. So whenever I think about the fusion or translocation-related driven tumors, there is often a monotony to them that is quite helpful in coming up with the diagnosis. Again, there will be vesicular chromatin with prominent nucleolus, slight amount of cytoplasm or scant cytoplasm. Tumor necrosis with brisk mitotic activity is usually there. And then occasionally you will see these areas of abrupt focal keratinization or keratin pearl formation. Just be aware that especially when you're dealing with a very limited biopsy from this site, it may not always be seen in the sample that you're looking at. And yet when you get a resection sample or something else, it is quite possible that you would then be able to see those particular features. Acute inflammatory cells are often very prominent in this neoplasm, and when they're seen, again, is a tip-off to the underlying neoplastic presentation. So here again, sheet-like distribution, just as I drove with the case a little bit ago. You will notice again areas of stroma in the background and a fibrous connective tissue stroma. And I will say sometimes this can be confused for osteoid production. And so the small round cell osteosarcoma category is also one of the ones considered within the small blue round cell differential. Here you can see tumor necrosis with areas of abrupt squamous differentiation. Here again, an area of abrupt squamous differentiation in a neoplasm that is otherwise quite monotonous. And finally, one additional area to show this very abrupt area of squamous differentiation deep within the tumor. So this is one way I don't rely on it being on the surface, because then I'm not sure if it's just part of the native epithelium versus being actually part of the neoplastic proliferation. Acute inflammatory cells are quite frequent, and here you can see them almost completely obscuring the neoplastic cells, and they are not lymphocytes. They are genuinely neutrophils and eosinophils as part of this inflammatory infiltrate. So when I look at the immunophenotypic profile, again, it's going to be that of a squamous cell carcinoma category, because that is where it is going to fit, even though it is a specific tumor classification. So here you will notice CK56 staining many of the neoplastic cells, P40 strongly and diffusely reacting with some of these neoplastic cells as well, while here you get to the nut. And of course, the nut needs to be a nuclear reaction, and it is very characteristic with this very fine speckled appearance within the nuclei of the neoplastic cells. Now, just a caveat, Sometimes you will see cytoplasmic reactivity with NUT when it is not a NUT carcinoma. So in other words, other neoplasms will have NUT present in the cytoplasm. And so you must be very cautious when you're interpreting this study that you are recognizing it to be a nuclear presence for a positive reaction. So as I've already suggested, it is defined by a nuclear rearrangement for the NUT-M1 with either BRD4 or BRD3. Of course, there are some other chimeric genes that can encode this as well, and other fusion partners that may not be known. And in that particular setting, they're referred to as NUT variants. However, still the NUT-M1 is part of what defines this neoplasm. As you know, FISH can be done to confirm this, and of course the RT-PCR and conventional cytogenetics may need to be done, especially if the person is going to enter a clinical trial in order to make certain that the fusion they have present is going to be represented. So just a diagrammatic representation of how these fuse, and of course if you do FISH, you would be able to see a break apart in this example. Well, you know, having mentioned FISH here, I thought I would actually show you something quite interesting. This is a jellyfish that I filmed while at the Monterey Bay Aquarium, and you will notice this very gorgeous fluorescence. Well, it is in fact the red fluorescence from this jellyfish that was used as the chromophore for FISH, and so truly it is a fish when you look at this particular in situ hybridization technique. This is an example from the patient, and I will tell you that approximately 2 weeks prior to her death, she had called me and said, I would be very happy if you would show my picture at the time that you present this case to others so that they will be able to give a diagnosis correctly to others rather than like myself, where I only had a very short time in which to deal with the diagnosis. And unfortunately, her husband contacted me shortly after this to indicate that she had succumbed to her disease. One of the major difficulties in this is with the blood-brain barrier being involved at the skull base, it is quite often that the chemotherapy agents will not cross and will therefore not work well. And so unfortunately for those patients who have head and neck-based NUT carcinoma, the prognosis is quite dismal. Sinonasal neuroendocrine carcinomas are, of course, another one of the categories where you have a very small blue round cell type appearance, and it must have both morphologic as well as immunophenotypic evidence of neuroendocrine differentiation. So I need to stress that here at the outset, because I really do think that many times people will become quite confused where they will have isolated areas of immunophenotypic neuroendocrine differentiation, and that does not put it into the category of small cell carcinoma or large cell neuroendocrine carcinoma category. It must have the morphologic features present as well. And so if you think about those, there are multiple different patterns that can be seen with ribbons and festoons, even gland formation, rosettes, solid fascicular architecture. Crush artifacts, of course, are quite common with tumor necrosis and generally a very high mitotic index, in fact, greater than 70% in many instances for a Ki67. It's usually quite remarkably infiltrative with perineural and lymphovascular invasion easily identified. And of course, the cytoplasm is usually quite limited with this very characteristic salt and pepper nuclear chromatin distribution without any nucleoli in the small cell carcinoma group. So the neuroendocrine features must predominate in order to have the tumor fit into this category. So here you will notice on low power that very ball-like architectural appearance, some even areas of central comedonecrosis easily noted. On higher power, you'll notice a very high NC ratio, nuclear crowding and molding between the neoplastic cells. In fact, when you look at other areas, that characteristic crush artifact that results from these cells being so fragile can be a clue to the underlying diagnosis as well. I think one of the reasons to perform a Ki67 in this is, of course, if you're trying to do a mitotic count or interpret some of the immunohistochemical studies, when there is this crush artifact, it can be really, really difficult to not overinterpret the findings that you see in that particular setting. Here you will notice a very nice, fine, even nuclear chromatin distribution where there are very well developed high NC ratio and very, very fine nuclear chromatin distribution, almost a salt and pepper nuclear chromatin. This is a large cell neuroendocrine carcinoma category. And in this case, I think you can see that the nuclei are much, much larger, still having a very high NC ratio. But now you will notice that there is a prominence to the nucleoli that are quite frequently seen in the large cell category. So I'm not spending time to separate between the large and small cell category, but just talking about neuroendocrine carcinoma as a whole. So when you look at the immunophenotype, here is an example of the CK-pan, and I think you will see that it is a very strong and diffuse reaction. However, in many of the cells, it is in a dot-like distribution. So in other words, you can see that there are these individual dots in the cytoplasm as they have accentuated in the Golgi, while there is still obviously membranous and cytoplasmic reactivity, but that dot-like reactivity pattern is quite characteristically seen in the neuroendocrine carcinoma category. P40, of course, will be negative in these tumors, helping to separate them from squamous cell carcinomas, and the same can be seen for the CK5-6. Synaptophysin, as you would expect, is a strong and diffuse reaction as well. Again, in this case, highlighting a few of the areas to show a perinuclear or dot-like Golgi type reactivity pattern. Of course, some of the more up-to-date markers for neuroendocrine differentiation, such as INSM1, can also be performed and will show a strong diffuse nuclear reaction in the neoplastic cells. However, having said that, you can also see aberrant expression with other markers, and here's an example of a TTF1 in a primary neoplasm of the sinonasal tract, and so this may cause some difficulty when trying to separate it potentially from a metastatic tumor from the lung or some other site where there can be aberrant TTF1 expression. One of the hallmarks of the neuroendocrine carcinoma category, and especially for the small cell type, is the universal and global loss of RB1. Here you will notice constitutively expressed neoplastic cells in the fibrous connective tissue stroma and endothelial cells that serve as a very nice internal control, but that all of the neoplastic cells are lost. So I think that doing the RB1, you will notice there's a lot of crush artifact here. So by doing this RB1, you're able to actually confirm the neoplastic nature of these cells and to be able to confirm a neuroendocrine type differentiation as well. I just want to highlight for a moment the RNA in situ hybridization for high-risk HPV. This happens to be a tumor that was growing in the oropharynx and then expanded up into the sinonasal tract, although you certainly can have sinonasal tract primaries that are related to active high-risk HPV. But just be aware that doing P16 alone is not a sufficient surrogate marker, and if you want to confirm that it is in fact related to HPV, you do need to do the high-risk in situ hybridization. As I already mentioned, there is usually a very, very high Ki67 index, and here you can see one that's well over 60% in this particular neoplastic proliferation. So again, if you look at all of the immunophenotype with that panel approach, I think you will see that there are several negative markers, but of course, the synaptophysin with some of the other more selected markers can be performed in order to be able to confirm the diagnosis. You know, I want to mention Teratocarcinosarcoma in this particular setting as well, because it is a very complex malignant sinonasal tract neoplasm that shows both immature as well as malignant, both endodermal, mesodermal, and neuroepithelial elements. And so there is a resemblance to an immature teratoma, even though there aren't any germ cell elements. But part of the reason this is challenging is because of the size of these tumors. Sometimes when they do a biopsy, they may only include some of the areas of the small cell or neuroepithelial elements, and this is why it falls into the small cell or small blue round cell category when you think about these neoplasms. They are usually remarkably large and very destructive. Here's an example radiographically where you can see, you know, this huge mass that's filling into the sinonasal tract, destroying all of the bone and filling out into the skull base in this area as well, and will often result in orbital involvement as well. Heterogeneous neoplasm showing features of both carcinoma, sarcoma, and immature teratoma, or these almost blastemal type immature neuroepithelial elements. And so with such a wide diversity in what you see, it can be quite a challenging tumor to come up with an accurate diagnosis. So here you will notice these primitive cells in the background that are the neuroepithelial cells with a bit more of an epithelial component, and then the spindled compartment here in the center, showing that all three elements are present in that single high power field. Similar features here, although I think you will notice that the squamous differentiation is at least quite easily identified in this area. Juxtaposition of a spindle cell compartment of a sarcoma with glandular epithelial elements quite nicely blended with one another in this single field. versus having an area here even showing you cartilaginous differentiation in the tumor, as an example of chondrosarcoma, while the small blue round cell appearance of these primitive epithelial and neuroepithelial elements can be present. So it is a very diverse histologic appearance to the gland and mesenchymal and primitive elements, and they all will blend with one another very haphazardly, and therefore make it quite challenging to be able to come up with the diagnosis. Bone destruction is quite frequently seen, and here you will notice an osteoblastic reaction to the neoplastic tissue as it is invading into the adjacent bone. So the immuno for this is actually all over the board, because each of the various elements is going to react with its particular compartment. And so you will notice that epithelial, spindled, and neuroepithelial cells all have different reactivity patterns. And so this is really one of the tumors when you do the panel approach and nearly everything is reacting somewhere within the tumor, it is actually a hint to the underlying diagnosis. You will notice that I've included NKX 2.2 and CD99 because, of course, those particular markers can be seen in those primitive or blastemal type elements. There is a universal loss of SMARCA4 in this neoplasm, and that is part of what helps to define the tumor as well. And this is something that has been recently identified within these neoplasms, quite similar to what can be seen with other sinonasal tract, both epithelial and neuroendocrine tumors. So let me just show you a few of these. Here you can see CK-PET. It's not staining everything, right? Because of course, some of the elements will react and some of them will not. Here's an example of CK56 highlighting more of the areas of squamous differentiation, while the CDX2 is highlighting areas of glandular differentiation. As I said, you can have adenocarcinoma present in these tumors as well. GFAP highlighting some of the neural elements, and of course, synaptophysin highlighting those of neuroendocrine features. So again, you do have a wide diversity of what you're able to see, with an example here of the SMARCA4 being lost, and BRG1 is the immunohistochemical study that is used to confirm this particular finding. So just be aware that the Teratocarcinosarcoma group is one of the tumors that really stains with everything except for CD45 RB, and therefore whenever you have something that seems to be staining with so many of the markers, at least have considered a teratocarcinosarcoma. Well, having gone through that entire exhaustive list, we're now back to sinonasal undifferentiated carcinoma, and am able to talk a little bit about that. Just be aware that it is a rapid presentation, very high level of metastatic disease, usually a remarkably destructive tumor, as you can see from these radiographic images. And then when you look at the pathology, there is quite frequently bone and surface ulceration, bone destruction, tumor necrosis, lymphovascular and perineural invasion with these very large monotonous polygonal cells with vesicular to open chromatin, and of course, very nice prominent nucleoli with a variable amount of cytoplasm, usually not plasmacytoid, usually not rhabdoid, and there should not be any surface involvement. In other words, no evidence of squamous differentiation or glandular differentiation in this tumor. So here you will notice islands of the neoplastic cells. When you go and look, you can see that it is destroying between the interstices of bone, giving you this very high NC ratio, but still easily identified prominent nucleoli within the vesicular nuclear chromatin. An example of vascular invasion here with multiple cells within each of the vascular spaces, so a very high lymphovascular invasion is seen. And then finally, just showing a single high power field to demonstrate that very prominent nucleolus in a vesicular and open nuclear chromatin appearance. So when we do the immunophenotypic evaluation, you will notice that you may have some focal reactivity with P40 or synaptophysin, but it tends to be a very focal finding and or just at the periphery where it may represent native cells rather than part of the neoplastic proliferation itself. By definition, of course, you should not have P63 or CK56, and the EBER will be strongly, should be negative as well. As I mentioned, IDH1 can be seen in this tumor, and I'll show an example of that here in a moment. So a very strong and diffuse pan-cytokeratin, OSCAR, AE1, AE3, whichever one of those you would like to use, usually gives you a strong and diffuse reaction in all of the neoplastic cells. CK7 is frequently found in this tumor as well, as you can see from this strong and diffuse reaction. However, you may have P16 reactivity in the tumor, and this does not change the underlying tumor category, and again, does not necessarily represent association with high-risk HPV. Here you will notice a CK56 and a P40, just highlighting that there is a non-reaction in the neoplastic cells, although again, you can see some of the basal cells at the periphery still being highlighted focally. And then, as I mentioned, IDH2, and it can be either IDH1 or 2, is quite frequently present in this immunohistochemical study, gives you a very strong granular reactivity in the neoplastic cells. As you know, there are therapeutic targets for IDH1 and 2, and so you can actually do a molecular study for it as well, as if you prefer, and therefore many times these patients are treated with sequential therapeutic modalities, although it still is a very poor overall outcome for most of these patients. One of the other differentials for the small blue round cell category include the Ewing sarcoma group. And as you know, this tumor is a fairly diverse group. I mean, I think Ewing sarcoma family is the preferred terminology for this because they are generally identified by the EWSR1 translocation, but not always. And so it is, of course, going to have this small blue round cell category, tumor necrosis, finely distributed chromatin, lots of mitotic activity. And of course, EWSR1 Fly1 is the most frequent translocation identified. You will notice that there is a defining group of positive markers. The CD99 and NKX 2.2 are actually one of the most helpful ones to perform as a duo. But you can see that NSE and synaptophysin, P63, keratin, CD56, a number of other markers are often present within these neoplasms as well, and therefore sometimes it can be quite challenging to reach an overall interpretation. So when I look at this here, you can see the adjacent tissue with this small blue round cell tumor. It's often quite monotonous. Again, it is a fusion-driven tumor. So even though there is variability and pleomorphism to the cells, they all have the same type of variation in each of the cells, giving you an overall monotony to the group. As you will notice, tumor necrosis is present here with abundant mitotic figures easily identified. When you look at them, they often will have a very monotonous appearance, again, with this fine and delicate chromatin distribution. When you do immunohistochemical studies, you can see a strong and diffuse cytoplasmic CD99, and of course, the EWSR1 break-apart FISH would be positive. Now, let me also include, however, the adamantinoma-like Ewing sarcoma, which is one of the neoplasms identified within the head and neck area, most often in salivary gland, but certainly seen in the sinonasal tract and thyroid as well, where it is a mimic actually of squamous cell carcinoma or nut carcinoma, because they are focal areas of squamous differentiation. Again, it will have that strong reactivity with the CD99 and NKX 2.2, but here you would also have co-expression of P40, P63, and or CK10. So when you look at the neoplasm, you can't really tell just looking at it that it's different from what you would see just with Ewing sarcoma. Here are two examples just to highlight those features that look quite similar to what I already presented. But in this example, when you look at the immunophenotype, you can see that there is going to be some overlap with them, especially with the P40, where it is not reactive in Ewing, but will be reactive in the adamantinoma-like Ewing category. So here is an example of the P40, an example with P63 showing a strong and diffuse reaction in all of the nuclei of the neoplastic cells. However, you can see that CK56 is also strongly reactive, and so this can be one of the tip-offs and one of the problems. If you only do a limited panel, you may say, wow, this is squamous cell carcinoma, let's move on. And yet, if you do the rest of the markers, as you will see, the CD99 giving you a strong and diffuse membranous type reactivity in the neoplastic cells, and then, of course, the more current marker of NKX 2.2 highlighting the nuclei in this example. Now, the NKX 2.2 is actually the downstream target of the EWSR1 Fly fusion and therefore is required for oncogenic transformation. And so it is something that is usually quite specific in this setting to be able to help to confirm the diagnosis of a adamantinoma like Ewing's or just a Ewing sarcoma family. Let's transition to actually a benign neoplasm at this point, which is included in the small blue round cell category. And this is the sphenoid sinus ectopic or pituitary neuroendocrine tumor. As you know, pituitary adenoma is no longer used with all of the new WHO books that have come out for both the CNS as well as for the endocrine and the sinonasal tract. Pituitary neuroendocrine tumor is what is used. And in this example here in the sinonasal tract, it's generally because of direct extension from an intracellular tumor that expands into the sphenoid sinus. So I will tell you that whenever I hear that there is a sphenoid sinus mass, I am going to exclude a pituitary neuroendocrine tumor no matter what. It is just something that if you get in the habit of doing, you're not going to be deceived and therefore miss the diagnosis. So I can tell you the number of times this happens is quite remarkable, because often the surgeon or the clinician will just say paranasal sinus, or they'll say sinonasal tract mass. They don't give you any of the specifics. And so whenever that happens, I just call the surgeon and ask them where they did their training and what part of the anatomy they were confused about, because as far as I know, there are many, many anatomic sites within the sinonasal tract, and giving the specific one is going to be much more helpful in reaching the diagnosis. Well, you only have to do that once, and then the next time from that point on, you will get very specific information about exactly where the tumor is being removed from. So if I can just highlight this diagrammatically here, you can see an example of the sphenoid sinus below with the pituitary right above. If you look at it here with the neoplasm, you can tell here is a completely ectopic pituitary neuroendocrine tumor, but obviously you can tell that it is in very close proximity to the pituitary and the sella as a whole. So when you look at this radiographically, you can see that here the tumor has grown in, and of course the surgeon is going to sample it as a posterior nasopharynx or upper sinonasal tract or sphenoid sinus rather than going into the pituitary area, but they still are going to know what the radiographic findings are, because no surgeon ever puts a needle or puts a forceps into an area without first knowing what's going on from an imaging perspective. And so they will know this information, and you just need to drag it out of them sometimes. So when you think about the pituitary neuroendocrine tumor category, lots of different patterns, as you know from any of the pituitary neuroendocrine tumor group, lots of different presentations to the neoplastic cells as well, ranging from polygonal and plasmacytoid, cuboidal, spindle, round, often having intranuclear cytoplasmic inclusions. And of course, you can have just remarkable pleomorphism and even tumor necrosis in some of these lesions. Remember, though, that for separation from other neoplasms, you tend not to have perineural or lymphovascular invasion, and also atypical mitotic figures are not identified within pituitary neuroendocrine tumors. They are often quite polypoid in their initial presentation. Here you can see two little fragments, and of course the amount of tumor that you can see on the left-hand side is really remarkably limited. Here is an area below an intact surface respiratory epithelium, and you can tell this very nice lobule of neoplastic cells below the surface. Of course, bone is going to be involved, because if it's come out of the sphenoid, if it's come into the sphenoid sinus from the sella, bone is going to be affected. And so you'll have either bone destruction or bone remodeling as it grows through that space, with a very nice area of reverse polarization in this region of the vessel. Tumor necrosis is quite commonly present, and here you will notice an area with genuine comedonecrosis easily identified. Sometimes the amount of neoplasm is incredibly limited, as you can see from these little small balls of neoplastic cells, and even worse so in an area like this, where the individual cells have nearly been completely replaced by a remarkable desmoplastic stromal fibrosis. And so sometimes when this is the biopsy type, someone will say chronically inflamed sinus tissue, and will actually miss the diagnosis completely, not recognizing that this actually represents a mass lesion. In other areas, the neoplasm is much more easily identified in its areas of organoid type presentation, an area of a pseudo-rosette present here in the center, with the neoplastic cells showing that characteristic salt and pepper type nuclear chromatin distribution. Again, as I said, you can have remarkable nuclear pleomorphism. And so in this example here, you can tell that it is quite remarkably pleomorphic. And it is in this setting that perhaps the immunophenotypic identification of the tumor would be of value. So again, if you look at the panel, you will notice the CK pan is positive as well as the synaptophysin, while the rest of the markers are negative. But you will see that PIT1, SF1, and TPIT are now used to be able to separate between these tumors before any of the other markers are added. And so here is an example of TPIT. You can see that it is a strong nuclear reaction. And in fact, all of the neoplasms in the endocrine section for the pituitary in the new WHO book have first been separated by the identification of these markers. Then if you go to the rest of them, you will notice, obviously, there is going to be an epithelial component to it. So you can see that CK pan is present in about 80% of these tumors, often in a dot-like reactivity pattern. And then a wide variety of different neuroendocrine type markers will be seen, with synaptophysin and chromogranin highlighted here just in this example. However, be aware that some of the other peptides and specific pituitary hormones will be present, with prolactin by far and away the most frequently identified when it occurs within the sinonasal tract, and it is not uncommon to also have multiple different hormones expressed in the same tumor. So just be aware that both neuroendocrine as well as epithelial markers need to be present for this tumor to be confirmed. And here, just an example of the prolactin giving you a very strong and diffuse cytoplasmic reactivity in this example of a pituitary neuroendocrine tumor. Well, no presentation of small blue round cell tumors is ever complete without including olfactory neuroblastoma. And so I must spend a few minutes on this tumor. As you know, it is a neuroectodermal tumor showing neuroblastic differentiation and a very specific anatomic site within the ethmoid sinus. So again, very similar to what I just spoke about with the sphenoid sinus and pituitary neuroendocrine tumors, the exact same concept here. If ever the ethmoid sinus is involved and there is a small blue round cell tumor category, I always consider an olfactory neuroblastoma. Just be aware that anosmia is actually a very uncommon tumor, uncommon symptom, even though the tumor may be quite remarkably destructive of that area of the olfactory bulb. The radiographic finding is actually quite helpful. You will notice a dumbbell-shaped mass extends across the cribriform plate of the ethmoid sinus, and so there will be extension into the skull base, as well as extension into the area of the ethmoid sinus or other parts of the sinonasal tract. So here is an example. You can see a biphasic presentation, skull base, as well as within the sinonasal tract. And then here is another example showing that it has directly invaded through that cribriform plate area, where you now have tumor both present in the base of the brain or in the skull base, as well as within the sinonasal tract. I think one of the most helpful features for this diagnosis is the lobules. So whenever I see multiple lobules, I always think about an olfactory neuroblastoma, because that lobular architectural appearance is maintained irrespective of the grade of the tumor. So when you look at low power, you can almost always see that lobular architectural arrangement. Quite frequently, you will have an intact overall olfactory mucosa. Sometimes, though, you can see areas of in situ involvement, although because the tumor is quite frequently missed until it is very large, the opportunity to see an in situ component is usually quite limited. As you know, they are larger than mature lymphocytes, but definitely the small blue round cell category, hyperchromasia, delicate nucleochromatin distribution, and inconspicuous nucleoli without any areas of tumor necrosis or increased mitotic activity in the low-grade tumor category. You may see aberrant epithelial, myogenic, or even melanocytic differentiation in an olfactory neuroblastoma, similar to what you see in the adrenal counterpart for the tumor, and therefore do not discount the diagnosis just because some of those alternative features may be present. Let me just show a couple of low-power images first to demonstrate that lobular architectural arrangement that is so easily identified no matter where you go. You can see these multiple lobules of neoplastic tissue, usually below the intact surface. Again, highlighting a very nice lobular architectural arrangement, very fibrovascular stroma easily identified throughout. The tumor cells are usually below the surface, and here you can see them in this very rich fibrovascular stroma that surrounds the areas of the neoplastic proliferation. Here is just highlighting an area where there is actually an in situ involvement with the surface squamous epithelium immediately associated with it. And I will say, if it's a superficial biopsy, you could be misled into thinking it is a poorly differentiated non-keratinizing squamous cell carcinoma, and hence the reason for at least recognizing that that may occur sometimes with olfactory neuroblastoma. You may have neoplastic cells that expand into other elements, such as you can see here with the minor mucocerous glands. And so again, sometimes glandular differentiation in the tumor is not necessarily present. It is just part of the neoplasm invading into and destroying the native minor mucocerous glands. So you do need to make sure that you recognize that particular phenomenon. That very, very characteristic salt and pepper type nucleochromatin distribution of a neuroendocrine type tumor is seen. And of course, you can notice that there is areas of tumor necrosis in this example here. Very, very sheet-like distribution of that lobule here, going up to an area of respiratory epithelium where there is mucocytes present as well. And again, this is surface involvement, not necessarily part of the neoplastic proliferation. As you know, there are some rosettes that can be seen, although generally in only about 30% of the cases, and they are named after the two people who identified them. For Homer Wright, that is actually his name. He was very egocentric as a surgeon, identifying the pseudo-rosettes with this kind of central cuffed or palisaded arrangement of neurofibril matrix material, whereas Flexer and Wintersteiner were two individuals, pathologists, much less common for the true rosette type formation of a tight gland-like or annular architectural arrangement. So this is an example of a pseudo-rosette. You can see the area of central neurofibrillary matrix material. Here again are areas of multiple small pseudo-rosettes present within this, and you can tell that there is quite a remarkable difference in the size of the pseudo-rosettes. Here is an example of a true rosette where you can see that there is a genuine glandular formation with a true lumen being identified within some of these true rosettes. So as you know, there is a grading system. This is based on the Vince-Hymes grading system, grade 1 to 4, with a very strong correlation to overall outcome and prognosis. And of course, as the grade increases, the tumor becomes much more difficult to identify. Well, I don't know how many of you actually know who Vince-Hymes was. I had the pleasure of working with him for a few years at the AFIP. He was a member of the Navy, supported the AFIP for several decades, very instrumental in training both ENT surgeons and pathologists, had more than 50 papers, 5 books, and the best platform is still named after him, with the grading system still used today. So if you look at that grading system, you will see that it is based on architecture, mitosis, anaplasia, matrix, rosettes, and necrosis, with as each of these particular elements are identified or lost or exaggerated, moves you through the various overall grading systems. And just to note again, the rosettes with Homer Wright only seen in grade 1 and 2, while the Flexer Wintersteiner are seen in the grade 3 and 4. So here's an example of a grade 1 tumor, no evidence of tumor necrosis, no mitotic activity, and a very bland overall proliferation. Here you have isolated mitotic figures, so moving you to a grade 2 tumor with slightly more granular appearance to the chromatin. And then here is a grade 3 lesion showing tumor necrosis with spindling and calcifications present within it. And of course, when you get to a tumor like this with a remarkable pleomorphism, very profound abnormalities, atypical mitotic figures easily identified, it's actually very hard to come up with the diagnosis were you to look at a tumor like this on its own. And so in that setting, doing the immunophenotypic profile will help you, especially since you're not going to have evidence of epithelial differentiation in most of the cases, and of course should also not have any evidence of other lines of differentiation other than the neuroendocrine type features. The S100 gives you a sustentacular framework reactivity, as you can also see with calretinin, GFAP, and SOX10. So any one of those markers can all give you that same reactivity pattern. So here's an example of the chromogranin giving you a strong and diffuse reaction. Again, if I can just point out that there is a slightly Golgi or dot-like immunoreactivity because it is also considered to be one of the neuroendocrine type tumor categories. A very nice and strong S100 giving you a sustentacular supporting framework, highlighting each of the lobules of the neoplastic proliferation. Well, you know, calretinin is also positive in this, and the reason I throw that in is because I don't want you to have stacks of slides like this, and rather to do a more focused profile with the original 7 or 8 immunos in each case, and then highlighting a few additional ones in order to confirm the diagnosis. That, of course, is my stack, but we won't talk about that. So Just a question to kind of highlight that there's always room for more research. How many cases were included in the Kadesh staging system that is in use today? And I'm giving you several things to select. And here, of all the things, 17, right? How many tumor classification systems would you be able to come up with today and only have 17 patients in the paper? However, stage 1 confined to the nasal cavity, 2, 1 or more paranasal sinuses, 3 extending beyond that, and of course to update it slightly with a modification to now include lymph node involvement. You can see that this particular staging system has been used throughout and continues to be used to this day. Let's transition to melanoma for a few moments. As you know, mucosal melanoma is going to arise from the melanocytes that are in the mucosa. Very protein manifestation for this tumor. Discohesive cells, junctional proliferation and pigment is obviously helpful. Peritheliomatous growth, when it's there, is also exceptionally helpful in diagnosing a mucosal melanoma. Since we're talking about the small blue round cell category here, though, I'm going to highlight just those features here in a moment, but recognize any one of the melanocytic markers can be present while the other markers should be absent. And so if you look at this, I mean, how would you come up with a diagnosis of melanoma here? It would be exceptionally difficult. Here you can see slightly prominent nucleoli, but otherwise no real distinctive features in this larger blue cell neoplasm category. Here is an example of that peritheliomatous growth where you can see that the tumor has aggregated around the vessels. And again, whenever I see that, my index of suspicion for something about melanoma is certainly going to be raised. You will notice that there are isolated neoplastic cells present within the surface epithelium with the otherwise intact respiratory epithelium as an example of in situ involvement. I think you will notice there is pigment present in several of the neoplastic cells when you see it on higher power. So again, the rest of the markers should be negative with only S100, and then of course SOX10 and HMB45 or some of the other markers helping to reach the diagnosis. So I do think that the SOX10 with a nuclear reaction is a very easy one to interpret, and especially within the small blue round cell category, doesn't tend to have a lot of overlap with the other tumors in the category. Here is an example of S100 with a nuclear and cytoplasmic reaction, and HMB45 giving you a nice cytoplasmic reaction, and of course melan-A rounding out the group here. So just be aware that any one of them can be used, and I will say that probably having more than one reaction is going to help you, especially when you're trying to exclude some of the rare tumors like a picoma or some other lesion that may co-express some of these markers. Alveolar rhabdomyosarcoma, again, is a small blue round cell category within the head and neck space. The alveolar rhabdo is much more common in the adult setting and therefore will fit into that small blue round cell tumor group. The alveolar pattern with this fibrovascular septa with the small cells kind of dropping off, giving you this dilapidated appearance with discohesion at the edge is quite characteristic of the tumor. And then, of course, you will have a immunophenotype that I'll show in a moment. Just be aware that these tumors can be remarkably destructive. This is actually taken from a young teenager as donated by my friend, Dr. Roman Carlos. The radiographic finding is again going to give you this very destructive lesion that you can identify as part of your gross interpretation, since so many times there is no grossing of these small blue round cell tumor categories. Polypoid area of neoplastic proliferation. You can see that it is being separated out by this very dense fibrous connective tissue stroma. When you go into higher power in different areas, I think the dilapidated appearance in the alveolar architecture is being represented with discohesive cells seen at the periphery. And then here, of course, you can see the very nice rhabdoid appearance to them with a pulled off cytoplasm giving you plasmacytoid or rhabdoid appearance to the neoplastic cells. Sometimes a strap-like cell may be seen, as you will notice in this example, where there are actually several strap cells present within it, but that's a very uncommon finding in my view with the small blue round cell tumor category. Now, having said that, I would like to point out that keratin can be present, as can synaptophysin, along with a variety of other myogenic markers, but just be aware that you may have co-expression with those markers, and this is a very important thing to remember since the management is going to be quite different. So I'm starting off with the pan-cytokeratin because I do want you to see that here you have CAM 5.2 strongly reactive in the neoplastic cells. And if that is all you did, I venture to say you would say it's a poorly differentiated squamous cell carcinoma or poorly differentiated carcinoma. However, when you add on the myogenin, you can now see that it's a strong nuclear reaction and therefore helping to get to the correct diagnosis of a rhabdomyosarcoma. So again, the desmin or myogenin, MyoD1, as some of the other skeletal muscle markers can certainly be helpful in reaching the correct interpretation in these cases. As you know, the FOXO1, either fused with PAX3 or PAX7, is very helpful. And here you can see an example of one of those break-apart probes in this example. Well, let's end now with the extranodal NKT cell lymphoma category, since the nasal type definitely occurs in this location. And, you know, you have to include the lymphoma category as well as, of course, plasmacytoma, which I'm not going to have a chance to discuss today. Suffice it to say that the discohesive cells and diffuse cytologically atypical angiocentric and angioinvasive tumor cells are usually quite helpful. But one of the problems with this is that very frequently you will have a pseudoepitheliomatous hyperplasia. And whenever I have that, it is always a squamous cell carcinoma category that is brought to mind rather than recognizing the neoplasm is in fact in the adjacent neoplastic cells. So as I look at this, I can see that there is a very, very strong and diffuse pseudoepitheliomatous hyperplasia that is expanding quite deeply into the biopsy. And yet it is these cells here in the background that are actually the neoplastic cells that need to be identified. You can see that there is often a peritheliomatous distribution. It tends to involve the vessels and therefore invade into them and destroy them. And this is part of the reason why you very frequently will have a tumor necrosis associated with it, as well as a very profound vascular involvement. The neoplastic cells, especially once the tumor has been well developed, are going to show these cleaved and irregular overall shapes, as you would expect with the NKT cell tumor category. However, I will tell you that many times the number of these neoplastic cells, especially early in the phase of the disease, are very, very limited and therefore can be quite difficult to recognize. And so many times additional studies need to be performed in order to reach an accurate diagnosis. Here again, you can see a kind of a spindled morphology, very, very crenated and folded overall appearance to the nuclei, which is again one of the tip-offs to the underlying diagnosis of the NKT cell category. Well, as you would expect, none of the other markers are going to be positive other than the CD45 and then a whole host of markers related either specifically to the T cell or the NK cell phenotype. And so in this example, I would like to just highlight the EBER. As you can tell, it is a strong nuclear reaction, which is usually a confirmative study for the diagnosis, just as it would be for a nasopharyngeal carcinoma, were that to be in the differential as well. But here you can see TIA1 giving you a nice cytoplasmic reactivity, and another example of granzyme, which is one of the NK markers that can be used to highlight this neoplasm. So just be aware, if you're using your panel approach here, once you have reached that particular panel, just be aware that at that point you may need to add some additional markers in order to be able to come up with the diagnosis and to be able to reach the correct interpretation for the overall small blue round cell category. So again, just highlighting the first letters of this so that you're able to recognize the Mr. Sleep category in order to be able to come up with the diagnosis. So I know that this is a lot of information to cover in a short amount of time, but I thought I would end with one of these questions just to give you hope. So which baseball player had the best ever batting average in the Major League Baseball? Well, I've listed 4 people. I think I was just disconnected for a moment, but let's see that I was just going to say he had a batting average of .366, which means he missed 63.4% of the time. So there is hope for pathologists because we definitely do not have that as our missing average. So we have to think very broadly when we are confronted with the small blue round cell tumor category. Try to use the radiology and other clinical findings to help you. Be very careful and considerate when you could do your immunophenotype. Doing a panel approach certainly looking at both the positives and negatives in order to be able to get to the right diagnosis, and then using selective studies in order to be able to confirm it. So I hope that in this particular setting, I've been able to go through the small blue round cell tumor category and be able to give you a diagnosis that you will be able to utilize and reach a correct interpretation in this example. So with that, I would like to thank you for participating. And if you have any additional questions or comments, I'll be very happy to take them at this time.